cancer and the EGFR mutation and its therapeutic application. I think one of the main progress which has been made in the area of non-small cell lung cancer is the knowledge about the driver mutation. And these driver mutations have made the life very easy in terms of the treatment. However, there are many problems associated with that. One is, of course, the drug resistance. And second is the appropriate correlation with the drugs, the newer and newer drugs which are coming up to really ultimately determine the appropriate therapeutic in particular EGFR mutation type. The commonest mutation is EGFR in the lung cancer. It almost consists about 20 to 25%. And these are the patients who respond well to the first generation, second generation, and third generation EGFR inhibitors. Among them, the most popular and most widely used is the osimertinib. All of us know that how it works well, and the median survival has improved up to even 4.5 years. And today we have a full agenda in which the speakers will throw a light upon the whole era of EGFR mutation and its application. The main speaker will be Dr. Mark Vincent, who is he's the professor of oncology at the University of Western Ontario. He is also the consultant medical oncologist at the London Regional Cancer Program. He holds several patents related to the potentiation of chemotherapy and targeted agents, and he's a co-founder and a chief executive officer of Sarisa company dedicated to the development of this technology. So with this, I would like to request the next speaker, Dr. Nikhil Ghadyalpatil, to talk to us on NGS testing in lung cancer.
Good evening. Thank you so much, Dr. Advani. It's such a great pleasure to be amongst the doyens in the field of medical oncology. I hope my screen is visible here.
Yeah.
And okay, thank you so much. So it's quite a interesting evening, which is expected in front of all of us, especially with Dr. Advani around and Dr. Mark Vincent. I remember hearing him almost a decade ago when I was quite fresh from my DM curriculum. So it's quite happy to see him today again one more time. And as Dr. Advani has already set the ball rolling in terms of the advances in the field of lung cancer management, more so in terms of therapeutics, especially with the newer targeted therapies, and how the science has evolved in the last couple of decades, and how the science has benefited our patients in the last couple of decades is something what one can say is a true success story when we talk about a cancer and its management. Now, when we talk about the newer therapeutics, in the same breath, it is quite important to understand the newer diagnostics which have really helped us understand profile the cancer in much better manner, and in terms of understanding the cancer in terms of its molecular level. And we have a plethora of tests which are available with us, and the newest kid on the block is probably the NGS, the next generation sequencing, which is going to be the core focus of today's presentation. Now, we have evolved from a lung cancer as one disease to the histology-based subgrouping, which includes typically what we talk about small cell, non-small cell, squamous, adeno, and so on and so forth. Now, in the last a couple of decades, as our understanding has got better, and that all related to the various tests, and that led to the detection of newer biomarkers, which also will have predictive or probably also would have prognostic connotations. And that has really paved way for newer therapeutics, and that is exactly what currently we are following in our day-to-day practice. And as you can see here, from one color, we are almost now currently in the era of rainbow of various therapeutic targets and prognostic targets also. And I'm sure maybe in the next couple of decades, as we move on in terms of oncology science, this color combination will further improve, or I would say we'll have further shades which can be added to this particular pie diagram. So typically what has happened over a period of time, the way we treated the patients in the past was all based on clinico-pathological factors, and they just try and understand bit of an histology and selected drugs for individual patients. But in the current scenario, in the current understanding, we know that a targeted approach in terms of identifying the targets so that the precision oncology can be exercised for the patient is of the utmost importance. And this can be done by either identifying the single agent or a multiplexed gene assay. As we understand, we have done this in the past in the form of doing a specific PCR test for EGFR. We have done a FISH for ALK, Sanger sequencing. These are all kind of time consuming techniques, especially the Sanger ones. And eventually only to go for small hotspot assays which can detect few genes in all together, and so as to come to some kind of therapeutic decision making. But with the advent of newer and next generation sequencing, where we can actually go through the entire profiling of the cancer genome, both at DNA as well as RNA level, and that can really help us understand what are the targets which we are looking at. Is it a single target? It's a multiple target? How we are really going to approach the patient. What lies tomorrow? Yes, we are already doing bit of a plasma-based assays with NGS. It is still far from absolute, I would say, true to its outcome. Having said that, it's always room for improvement over here, and somehow to a certain extent we are already using part of it in our day-to-day practice. So coming back, histology subtype, then we move on to do IHCs for certain markers like ALK, ROS1, MET, PDL1, definitely what we do in day-to-day practice even now. And then we also had the facilities of use of FISH, which we basically exercised for ALK to begin with, and of course ROS1 and other I would say targets over here. But with the availability of next generation sequencing, one can actually have quite a significant number of mutations which can be looked into, which might be predictive mutations, which can help us in decision making in terms of treatment management. One can look into mutational burdens, rearrangements. And when you look at the liquid biopsies like the ctDNA or cell-free DNA, you can also look for certain resistant mutations like what we are doing currently, like T790M. And of course, monitoring also exercises which can be done or which are already being done in various clinical trial settings for now. So what is NGS? It's a kind of a technique which is basically try to look into massive parallel sequencing a lot. It's a very high throughput technique which looks into multiple genes in one go. It has a very high sensitivity when you talk about the conventional Sanger sequencing, which is slightly cumbersome. A very tiny amount of tissue would be required to really run a proper NGS, both at DNA as well as RNA levels. And that is something also has helped us getting the diagnosis or I would say the biomarkers in much better way. We do understand tissue has always been quite a challenge when we talk about lung cancer patients. The tiny tissues sometimes make life difficult, and doing the test in a more of a sequencing is at times can be extremely challenging to really get the diagnosis or I would say therapeutics going for these patients. So here we have one test which is high throughput, highly sensitive, rapid, it requiring a very tiny amount of tissues. And when you talk about why these tests are all being exercised, as we discussed in the previous slide, these are the long list of drugs which are available just because we could identify newer and newer targets. By no means this list is complete, and I'm sure this list will continue to grow forward and continue to get more and more busier as we move on to next couple of decades. So what happens when we look into single gene reflex testing versus multiple genes testing by NGS? Now, I think something which we have done, we all have started with single gene testing in our clinical practice a few years back, where we looked into EGFR. The EGFR is negative, then one can think about ALK. Sometimes we started sending EGFR, ALK, and ROS1 together. But this back and forth technique also leads to bit of a treatment delays, because as till the time the reports are available, it can be at times be challenging. Having said that, when you talk about a test like NGS, which is like a one shot testing, which looked into multiple genes in one go, and the results can be quite fast, and at one go we can have entire information available, and there is a much lesser chance of missing information in this setting. So this is how probably the patient-centered treatment emerging paradigm. I know one test, one target, one test with multiple targets one can look into, identify your target, and accordingly decide on to the therapeutics. And that is how probably would be the right approach for the patients. We had a challenge when we probably didn't have the NGS available, but now with a lot of supports from various pharmaceutical companies, these tests are quite easily available even at the RNA level NGS. So that's quite important and quite helpful for our patients also. And that has also led to, kind of quick decision making in terms of treatment management, and yet not missing on to a lot of information that is equally important here. So when you look at what are the kind of genomes which we are looking at when we try and understand the entire cancer genomics for, let's say, for lung cancer or for any other cancer, you are looking for either mutations, you are looking for chromosomal aberrations, or you are looking for certain translocations. When you look for mutations, we know for sure that there can be substitutions, indels, that is insertions or deletions of amino acid. Typical mutation example here one can quote is EGFR mutation. Chromosomal aberration, gene copy number, as we know, HER2 is a typical example over here. And there are certain genes which would be deleted, and these are kind of also can be picked up. So how which test, which average is what we are looking at is all depicted in this particular slide. And current technology, when we look at to identify all these things, we require quite a combination of various tests. It can be time consuming, it can be finance consuming at times also, because every test comes with its own cost, and it also probably need to be done in sequence, and it will be quite cumbersome for everyone to really look into that. Vis-a-vis, when we talk about this massive parallel sequencing NGS, we can technically probably might get almost all the information in one go, and that is what we should be looking forward to. And as we understand, this NGS has been expensive when it initially started, when you talk about initial exon sequencing. However, as we understand, the cost seems to be coming down, as you can see from this blue graph here, that the cost eventually is coming down quite significantly over the last decade or so, or more than that. And as I mentioned over here, the Moore's law, which does tell us that, as more and more tests will be available, the cost would be expected to come down. And that is exactly what has happened when we talk about the NGS testing and its economics. So these tests are definitely much more affordable than the time when it was initially implemented in the clinical practice. A quick overview. Now this is quite a challenging slide especially for clinicians, and it's a long sequence what typically is being followed when we talk about NGS. The DNA fragmentation for library preparation. Just to give a brief background, this is something called as preparation. a good preparation followed by good analysis followed by good results is what NGS is all about. And as we understand, there is definitely, once the proper library is enriched, one can subsequent test would be to you do the paired and end NGS. Alignment is quite important. Eventually, one has to really read what has happened and compare with the comparators or what are the information what we have with us. And eventually, when you compare with the informatics, eventually the report is being prepared. Just to simplify the things, what I just now have mentioned, a good sample collection followed by sample preparation. This is subsequently followed by the library preparation and sequencing. These are quite important tests and steps for when you talk about NGS. And these are quite critical because anytime when the things go wrong, the results may not give, we will not get the appropriate results over here. And last but not the least, the dry lab, that is the proper analysis and how we interpret the results. When you get this high throughput test, a lot of information is available and one should try and make sense why we are, what we are actually looking at and how we can interpret this particular data and how we can apply to our patients. So that is something which is important. Sample collection, as we know, most of the time it's a tissue collection, but of course liquid biopsy is also I would say making the deeper and longer strides in this regard. A good sample collection is of paramount importance. This is subsequently this eventual tissue is eventually run and eventually the libraries are prepared and subsequently the sequencing is done over here through one of these platforms, as you can see over here. And this is quite important step as you try and understand the analysis, as you get a lot of information, that is the output. Is an important step remains the alignment and try and understand what kind of particular alignment you are looking at, and then try and see what is variation what you are looking at, and eventually one can eventually come to the output or the final results of this test. So a quick word about the clinical implementation. Whatever we have discussed till now, NGS has its own advantages. As mentioned, it's a high throughput technique. Multiple genes can be tested in a very systematic manner. Majority of the aberrations, insertions, deletion, translocations are normally can come under the gamut of NGS and can be easily detected. And also it's quite precision. So definitely when you look at, as I mentioned, the cost continues to come down. Individual tests may cost much more when you, as compared to when you talk about a panel of NGS, which can be much more cost effective. Sample procurement, and there are other pre-analytical issues here. What we do understand, especially when there is issues with the fixing of the specimen, at times you may not get a good sample just because of the aging of the sample. The extraction of DNA and RNA can be a challenge at times, especially with the older samples. And at times, when we do not have good sample with the FNSEs and all that, one can have very poor number of cells. And there, this particular test can be a challenge. So these are typical challenges what one can be looking at when we talk about NGS. So a good tissue is of extreme and paramount importance when you are applying the NGS platform for the testing for the targets. And this is one of the Indian studies, which again done by Dr. Anurag Mehta from RGCI, which looked into this NGS validation in the Indian context. Interesting to note the conclusions that it is one of the first studies from the Indian context, which looked into the validity, analytical validity. And they could conclusively say that this is something which can be manageable and which is very much possible in the Indian context, especially when we want to determine the actionable mutations. So this study holds its own importance when you talk about the Indian context. And this is going to be probably the future of the studies, where till now probably we were looking at one target, one study, and here is maybe one of those studies which looked into multiple targets and accordingly try and understand what kind of targeted therapy which can be applied. So that is probably would be feasible when you apply an NGS, and all of a sudden it unlocks or unleashes the potential of a study where multiple targets can be identified, and same time it will be easier for the to get many more outputs or results when we have studies like this. So that is something which will be very interesting to see. Of course, it's the eventual study dates are quite far away, but I'm sure more and more studies would be going in a similar direction. So what are the takeaways for today from today's presentation? We do understand biomarker testing is here to stay. I am sure as long as probably it is possible, it is something what should be done for all patients. What techniques? I think what I already discussed a lot about NGS, which has shown quite immense promise, not only for future, but also for the present scenario. And when you get NGS panel, it also helps you getting multiple tests tested. It's kind of cost effective, accurate, highly sensitive assay. And of course, we do understand that it also gives us information which targets which can be utilized for the patients. And as we understand, there will be a couple of challenges, especially in terms of samples and test requirements, availability, accessibility, especially the rural parts. And this can be these are certain challenges which, as in India, are quite equally important. And I'm sure over a period of time, this will also be overcome with further access of NGS in terms of biomarker testing in non-small cell lung cancer. So with this, I'll stop here. And if you have any questions, I can take, or I'll pass on the podium to the organizers.
Thank you so much, sir. If you have any questions, if the audience has any questions for our esteemed speaker, we request you to please put it in the chat box. So due to want of time, can we move on to the next session?
Sure.
Thank you, sir.
Absolutely.
Thank you, sir. So I now invite our international speaker, Dr. Mark Vincent, to please present his slides. He'll be talking on the topic, establishing the current therapeutic strategy in EGFR mutant NSCLC in 2022. Over to you, sir.
Thank you. Can you hear me?
Yes, sir, we can hear you, sir.
Okay. So thank you to the organizers, and good evening, all of you. It's morning here, but it's good evening to you. And I appreciate the opportunity to speak again in India, and at some point hope to visit in person. So I'm going to be talking about establishing the current therapeutic strategy in EGFR mutated non-small cell lung cancer. These are my disclosures. I'll be happy to share these slides with anybody. First topic is actionable biomarkers and mutation testing. Now, we've had a good talk on this, so I'm not going to dwell on this, except to say that international guidelines strongly recommend testing, particularly non-squamous non-small cell lung cancer, for EGFR, ALK, ROS, BRAF, NTRK, MET, exon 14 skipping, RET. But in addition, we have some newer targetable mutations revolving around HER2, NRG, and RAS, and of course the immune biomarker PD-L1. And now you've seen the slide. This is the pie diagram. It's continually getting updated. It's evolving, and many of these are now targetable, which they were not before. And you can see on the table here on the right that there are at least 8 or 9 targets with drugs that may or may not be accessible, but are becoming increasingly available, and in the course of time will become cheap and accessible to mass markets. Now, oncogene addiction has been mentioned as a spectacular opportunity that's been presented to us over the last 10 years to help our patients. And you can see that patients who have actionable mutations but who don't get targeted treatment do fairly poorly. And they do really only as well or as badly as people with no drivers. But if they get access to a targeted therapy, their median survival may be improved by as much as a year, and in fact, probably more than a year. So just to focus on EGFR now, histology, we group all of these things as a non-squamous non-small cell lung cancer or adenocarcinomas. But you can see that there's a whole variety of histological patterns that can be included under this big umbrella. And just to make the point that if you see these words papillary or micropapillary, they're perhaps more likely to be associated with some kind of driver mutation, particularly EGFR. Whereas if you see the solid, poorly differentiated kind of cancer, maybe more associated with smoking and a KRAS type of mutation. But this, of course, is not absolute. And basically, the bottom line is that anybody with a non-squamous non-small cell lung cancer should have access to some kind of sequencing. And just going on the histology really only gives you a very kind of a crude clue that something's going on that might be very actionable. Now, EGFR mutations, as we've heard, are probably the commonest driver mutation, certainly the commonest driver mutation in patients with light or ex-smokers or never smokers. And the common mutations are listed as deletion 19 and exon 21, but also there's about 15% that are uncommon, and I will spend a little bit of time talking about those. The actionable mutations, exon 19 deletion, deletion 19, exon 19 and exon 21 point mutations really tend to occur in this area here, close to or at the ATP binding site, and not really so much at the extracellular domain or the transmembrane domain. And the TKI drugs are designed actually to get in the way of ATP binding, and they interfere with EGFR activation in that way, even in the presence of a mutation. And this is just another cartoon to show the tyrosine kinase domain. And this is where the action is here, stretching really from exon 18, really all the way up to exon 22, but really localized mainly in exon 19 with deletions. It's most of the mutations, or certainly a big chunk of them, and point mutations in exon 21. But we do have these other atypical mutations in exon 18 and exon 20, and also a couple in exon 21 and even in exon 22, which can also be driver mutations and which may be druggable as well. And if we've got time, we can talk a little bit about that. So we have many different options going from the original first generation, the second generation, and more recently the third generation drugs that can block the activity of EGFR. And these can be given as single agents or in combination with chemotherapy or with VEGF or VEGFR blockers. And there are a couple of very well-known studies, such as FLORA, looking at osimertinib in a randomized setting, dacomitinib versus gefitinib, and the afatinib studies, and the studies with erlotinib, which is a first-generation drug, but combined with either bevacizumab or ramucirumab. And all of these have shown some kind of promise of improvement. And the question really is, how do we choose amongst them? But here is in 2022 a widely accepted standard of care across the world, and certainly in my country and in the United States and elsewhere. So, for example, we would commonly start today with osimertinib in the first line. In second line, we would default to platinum pemetrexed. Bevacizumab is not really funded in my country, but it is in other jurisdictions. Third line would be docetaxel, which may or may not be combined with ramucirumab. And after that, really, we're talking about best supportive care or palliative radiotherapy. And I just do want to make the point that radiotherapy can be utilized anywhere along this journey from first line to final line and best supportive care. And that is an important thing to remember, and I won't spend a lot of time talking about that. This is a treatment algorithm that's encompasses maybe the last 5 to 10 years. Again, what I've talked about, first line osimertinib, but in the patients who can access, say, first or second generation in the first line, when that fails, which it always does sooner or later, you should test for the T790 resistance mutation. And where it's positive, we have osimertinib, which is a very effective drug in the second line setting where it was initially introduced. If it's EGFR T790 negative, you would default to chemotherapy. Now, the attributes of osimertinib, which I'm going to be talking about, is obviously an asset of AstraZeneca, who's sponsored this meeting. Is the wild type EGFR, the EGFR mutation, and the EGFR mutation with the T790M mutation. Drugs in the first and really also the second generation do not discriminate between the wild type EGFR and the EGFR mutant forms. And as a result, you get significant toxicities, particularly skin rash and diarrhea. but also nail problems, which can be very, very bothersome. Osimertinib is much better in the sense that it does not really bind significantly to the wild type EGFR, or only slightly, but it is designed more to bind to mutated EGFR, and especially if there's a T790 mutation. So it's much more selective. And as you can see in this kind of stick diagram here, this is gefitinib in the binding pocket. And this works very well for as long as you don't have a T790 mutation. If you have this bulky T790 mutation, this will create steric hindrance between this particular side chain of the gefitinib molecule, and it will push the gefitinib molecule out of the binding pocket, so it's not effective anymore. And so that's a common drug resistance mechanism that occurs in many patients on first and even second generation. But osimertinib has been designed so that this steric hindrance does not interfere with the activity, and so osimertinib can stay snugly in the binding pocket even if there's a T790 mutation present, or whether there isn't. So it's not specific for T790, it's just active whether T790 is there or whether it's not. As I said, the T790 is a common mechanism of resistance on patients who have had first and second generation TKIs. There are, of course, others that we'll talk about, but the T790 emerges in 50 to 60% of patients who have failed on first generation, such as gefitinib or erlotinib. Now, the AURA3 study was designed to look at this problem in patients who have had a first generation TKI, failed on it, and had the T790M mutation, and they were randomized to osimertinib or platinum pemetrexed in a 2-to-1 ratio. And this showed a very marked benefit over chemotherapy with a hazard ratio of 0.3, which is not the kind of hazard ratio that you see very commonly, and the median PFS increasing by about 6 months from 4.4 to 10.1. Now, the problem with this kind of an approach, which might be very acceptable, is that not all patients get to second line. So this is a whole range of these studies, some of which I've mentioned, showing how many start off with the first or second generation TKI, how many actually get to second line at all. And you can see that it ranges from a low of about 49% to a high of about 88%. But really, it's about a third of patients who will not get to second line. And for that reason, it is, if it's possible from an access point of view, to use the best drug first so that everybody gets access. So, and there are problems, of course, as well in trying to show that somebody's T790 positive, because you have to get a second biopsy, and that's difficult, it's expensive, there are hazards, it causes delays, you need sophisticated sequencing, you might not hit the right particular tissue, there's the metastases are different necessarily one from the other, you may just hit the wrong one because it's more accessible. Now, the liquid biopsy is good in this context, but if it's available, but it's not always available, as we've heard. Now, what about moving osimertinib into the first line? And this was done through the FLORA study, which randomized patients with common mutations, deletion 19 and 858R. And these were balanced between the two arms, osimertinib compared to dealer's choice of gefitinib or erlotinib, with the crossover allowed. And the overall survival was a key secondary endpoint, with progression-free survival as a co-primary endpoint. And so we see here, again, a large benefit over the comparator EGFR TKIs, and the progression-free survival really favors all subgroups. All of these 95% confidence intervals are well to the left of the unity line, and this includes patients with EGFR deletion 19, as well as exon 21, and whether you have CNS metastases or not, whatever the ethnicity, the age, the gender, or the smoking history. So this was a strikingly positive study with a median progression-free survival of about 19 months compared to about 10 months, which is what we all know from first generation. This is very striking. In terms of the overall survival, we now have some quite long follow-up here, and we see a hazard ratio of under 0.8. With a really these curves split early and they don't really come together again. And so the median survival now in this population, just under 40 months. And I would emphasize that this contains a lot of Caucasian patients and not just Asian patients. Asian patients perhaps tending to survive longer just inherently, but this is a mixed population, Caucasian and Asian. Median survival, as I say, more than 3 years. This is what happens if with patients with CNS metastases. One of the attributes of osimertinib is that it's strikingly penetrant to the CNS without causing CNS side effects. And this is quite unlike gefitinib or erlotinib. If you want those first-generation drugs to get into the CNS, you have to crank up the dose. And when you crank up the dose, you do get a lot of side effects that really make them unacceptable. So CNS hazard ratio of 0.48, and you see the very significant responses here. It's not to say that you won't get responses in the first generation, but they're not as good, they're not as durable, and you will certainly, it's not likely that you will get significant incidence of complete responses. Now, the survival was certainly better in deletion 19 than exon 21. But I want to emphasize that even in exon 21, the progression-free survival was substantially longer and the CNS control was much better. So, and of course, there is less toxicity for the reasons I've explained of selectivity of this particular agent for the EGFR mutation and less so for the wild type, resulting in much less in the way of skin rash and also less in the way of transaminitis, because that can also be a problem with the first generation. And all of these parameters, PFS, time to first subsequent treatment and second subsequent treatment, and PFS2, and the overall survival were substantially in favor of osimertinib, so that the NCCN and ESMO guidelines, if we look here at the NCCN guidelines, they're a bit easy to see, osimertinib in the EGFR mutation first line is a preferred drug, although you can use these others for sure, but osimertinib is a preferred drug. So what are these attributes of osimertinib that are attractive? One is superior PFS and OS compared to first generation. It's highly active in the T790 if you want to use it in second line. It has outstanding CNS penetration without the CNS side effects. It is less toxic than the other available TKIs. And by the way, it's especially less toxic than afatinib and dacomitinib at the recommended doses. It can be safely combined with VEGF inhibitors. It can be safely combined with chemotherapy, but it cannot be safely combined with immune checkpoint inhibitors. It's really important to remember that. And you should not use it straight after immune checkpoint inhibitors either, because they require time to wash out. But you can use immune checkpoint inhibitors after osimertinib because that washes out pretty quickly. It's safe to combine probably with radiotherapy or in close proximity to radiotherapy. We're currently telling people on radiation just to hold these drugs till just before and just after the radiation. But that's just really out of an abundance of caution. And there are large international clinical trial programs that are ongoing with a strong commercial partner with AstraZeneca. So what might change in the future? Well, you can combine first generation with chemotherapy. This has been done in Japan and in India, and it has been shown to be advantageous with respect to a fairly decent progression-free survival, doubling really from about 10 to about 20 months. The median survival in this Asian group of patients was substantially prolonged with the addition of chemotherapy. But of course, you know, what you engender, firstly, you use a line of treatment that you may not have to. And secondly, you expose people who may not need to be exposed to chemotherapy early on to the toxicities of chemotherapy that we are all extremely familiar with, the nausea, the vomiting, the neutropenia, pancytopenia, etc., as well as the inconvenience of having to have something intravenous on a more regular basis. And of course, we're trying to keep people out of the hospital now because of the COVID situation. And so IV chemotherapy really brings them back into the system, and that's not something that's desirable if you can avoid it. The Indian study, of course, famous around the world now with gefitinib versus gefitinib, carboplatin, pemetrexed. It's the same sort of thing. You see this significant benefit. And this, of course, in patients who are unable to access osimertinib, for example, I think is a very reasonable strategy. And this was a great study. And we're very happy to see this kind of work coming out of India, where we know there's a lot of patients and a lot of potential for clinical trials. But of course, there's the toxicity. Now, in terms of comparing these across, you really see some of the best overall survival for FLAURA compared to afatinib or dacomitinib. The overall survival, I think, in the Indian study, and at least not to my knowledge, published, and probably very good, but again, with the downside of exposure to chemotherapy. So we have now the addition of anti-VEGF. This has been shown to be beneficial to erlotinib in particular. The studies with osimertinib is currently ongoing. And this is the relay study with deletion 19 and exon 21 progression-free survival, adding bevacizumab to erlotinib. And so far on the second line, in terms of bevacizumab, second line with osimertinib does not seem to be a particular role. This was a negative study. But nonetheless, in Japan, they did do a first-line study of osimertinib with bevacizumab, showing curiously in patients who had a smoking history and still were EGFR, there seemed to be a benefit in first line of adding bevacizumab to osimertinib in the ever smokers, but not so much in the never smokers. So a little bit of a curious anomaly there. We don't fully understand this, but it seemed to also occur that there was maybe more of an advantage in exon 19 than exon 21. This is an evolving story. And one of the other interesting findings that there was a lower incidence of pneumonitis. All of these EGFR TKIs can cause pneumonitis. There was a lower incidence of pneumonitis with the bevacizumab. So a little bit of an interesting tweak there, and we're going to see how that unfolds. There's, of course, a big program with osimertinib, the adjuvant ADORA, the stage 3 post-chemo radiation. We're waiting on that. The ADORA, very positive, and then FLAURA2 OSI with chemo, and then with these drug-resistant mutations, so particularly MET amplification with this drug savolitinib, which I'll talk about very briefly. The ADORA was an adjuvant post-resection study, very, very positive, 1B, 2, and 3A. That's not my topic today, except to say that in the future, because of this study and the positivity, will become a standard of care in resected EGFR mutation early stage. And now what does that mean when some of these people relapse? Because some of them will relapse when they're off this in a couple of years. Can you re-challenge? And we are doing a re-challenge study here in Canada, which I'm the PI of with one of my co-investigators. FLAURA2 chemotherapy, does osimertinib alone or osimertinib with chemotherapy? How's that going to pan out? That's underway. We don't know. Just to make the point that there's a co-mutational burden with P53. If people have EGFR mutation and P53, that's worse than just having the EGFR alone. So the co-mutational thing is something that we increasingly have to take into account, especially in terms of prognosis. How we address P53, we don't have drugs for it, but they are in development. Liquid biopsies, very important to establish, is there any residual disease after surgery and what are the resistance mutations? Just mentioned stereotactic radiotherapy is now being incorporated into guidelines, NCCN and so on. And this is a study, a randomized study of patients, frontline systemic treatment with lung cancer, non-small cell, had less than 3 non-progressing lesions, were randomized just to continue on their systemic treatment or surveillance or to add local consolidative treatment, which could be stereotactic radiation or surgery. And you can see that the addition of the stereotactic radiation had a survival benefit, which was enduring even out to 4 years or more. So that's a strategy you can think about as well, even with EGFR or with anything, in fact. What about immune checkpoint inhibitors? I would just say that overall, most people believe that they are not that effective, as you can see here, compared to the wild type EGFR. However, there are studies that have suggested, in fact, this is a negative study showing they really don't do well on nivolumab. But there's this IMPOWER 150 study showing that in the context of atezolizumab, bevacizumab, there is a small population of EGFR patients who seem to do a bit better, but this is only 25 patients really, so very small numbers. And so right now, most of us believe that immune checkpoint inhibitors are not that effective in this population. What about the smokers? And there are smokers with EGFR, maybe occasional benefit, but you have to be very careful. Please do not put EGFR TKIs of any sort, osimertinib or otherwise, at the same time as an immune checkpoint inhibitor or just after an immune checkpoint inhibitor, because the risk of pneumonitis, including very serious pneumonitis, is quite high. What about conventional therapy? Just to say that after a TKI has failed, that the response rates to platinum pemetrexed seem to be what you would expect. The median survival with platinum, carboplatin pemetrexed, a bit better than monotherapy pemetrexed. So response rates reasonable, but again, it's not a long-term answer. What do we know about resistance? There are multiple resistance mechanisms. Many of them are not targetable, but I'll just say that MET, and I will just mention MET amplification is a mutation, is a bypass signaling particular. This is something that can potentially be targeted, and reversion to small cell or change transversion to small cell or squamous can be targeted with chemotherapy, although it's not actually that effective. I'm just going to move on in the interest of time. This just shows first-line osimertinib, about 15% will have MET amplification. There are other mutations that are not targetable at the moment, but MET amplification, there are drugs that can address MET amplification. This is after the comparator arm MET amplification is not so frequent, but the T790, of course, is, as I've mentioned. I'm just going to mention to say there are MET inhibitory drugs, and they can be combined with osimertinib. These are patients who've had osimertinib. Some of them have not had osimertinib, but can be given with osimertinib. Savolitinib is an anti-MET drug. This is capmatinib. It's another anti-MET drug, can be given with gefitinib. So MET is something that can be addressed, and I think in the future we will be assaying it. There are ongoing studies such as the Savannah study and so on, which have shown efficacy of anti-MET drugs. Here's another interesting drug, an antibody that's a biphasic, bispecific for MET and EGFR that can be combined, used by itself or used with another third-generation drug, lazertinib, in patients who are resistant to osimertinib with some degree of responsiveness. There are ongoing studies, previous studies like Chrysalis, showing really quite good activity here. The CNS penetration is a little bit open to question at the moment. But if you have MET expression, this drug is more likely to be effective. And so looking at MET and assaying MET is going to be something important in the future. There are randomized trials, particularly this one, Mariposa, amivantamab plus lazertinib versus osimertinib. We'll see how that pans out. There are antibody drug conjugates such as patritumab deruxtecan, showing a very striking effect. And I think these antibody drug conjugates are going to be very important right across the board in non-small cell lung cancer. TROP2 is another one, can be linked to a Tecan-like drug. Basically, NCCN says that if you have just a focal disease progression, you can treat that locally with radiation. You can continue on osimertinib treatment beyond progression. And so it's not necessarily that you have one little area getting out of control. You have to stop the drug when 90% of the disease is still under control. You can treat these areas locally and then continue with the osimertinib or any other kind of treatment in lung cancer. Why would you throw away a drug where it's still controlling 90%, 80% of the disease? Re-challenge with the TKI. There is some data from first generation TKIs that you have first generation fail, go into chemotherapy, and then you can re-challenge with about an expectation of disease control, some people responding, some disease control, perhaps 40 to 50% plus with this re-challenge. But when it's been looked at formally, the actual response rates are not that high, about 5%, but about half the people will get disease stabilization, which might extend their survival. So this is an interesting strategy. We believe that this might be useful for osimertinib. We have started this Ocelot study across 10 centers in Canada, where they get osimertinib first line, then chemo when they fail, and then re-challenge with osimertinib again. And they can come on study after osimertinib failure or after second line failure, and then get re-challenged in the third line. These are the objectives, the really objective response rate. We're doing a lot of translational research along this with serial biopsies. The other thing that we're also doing in the studies, including these atypical mutations, because osimertinib has some activity in this uncommon mutation, which I'll just summarize briefly here. These are grouped as group 1, 2, and 3. Group 1 is really what we're focusing here. These such as exon L861, G719S, and also S768I, and not the de novo T792 exon 20. Afatinib is active in some of these mutations for sure, but it's toxic. But if you have a good response, you'll get a good PFS. And afatinib up till now has really been seen as a standard of care with a response rate of around 50 to 60% in these canonical atypical ones such as G719, L861, and S768I. But it is toxic. We know that the osimertinib in vitro is active, and there's also some data now published on osimertinib activity in these atypical mutations, showing that the activity is pretty good, about 50%, pretty much the same, maybe a little bit better than afatinib, depending on the precise mutation, but less toxic. And in our study, we had an update to say that we have 3 with G719X, 2 of them are PR, 1 stable, 2 patients with 861, 2 PRs out of 2, and 2 patients with a combined 719 and 768, 1 PR, 1 stable disease. So that's 5 out of 7 having a formal response so far early on in our study. So we're very encouraged. We're going to continue to enroll these people in first line with these atypical mutations. So in the future, maybe osimertinib plus platinum pemetrexed, perhaps if FLAURA2 pans out, or maybe adding bevacizumab, especially in smokers. Maybe it's going to go like this. This is just a speculation. In the second line, amivantamab plus lazertinib, or the addition of a MET inhibitor if they're MET positive, perhaps. patritumab deruxtecan or one of these other antibody drug conjugates, and maybe with SBRT at any stage, and only finally docetaxel. So I think things are going to evolve like this, something like this over the next couple of years. And so this could all change. Now, just a little bit, coming to the end here. We know that lung cancer is an issue in India, and there's increasing good academic work coming out of India. For example, lung cancer is the leading site of cancer for males in several of the population-based registries of the NCRP, coordinated and steered by the ICMR NCDIR. And we know that, for example, about 30% of patients in India now appear to have EGFR-driven cancers, perhaps a little bit more in females than in males, but overall about 30%. And we know that access to drugs, of course, depends on resources. Many of these people will get first-generation TKIs, but there's a high degree of CNS progression in that setting, and osimertinib might be a solution. And with that, I can come to a conclusion, and I don't know if I've got time to show a case or not. I'll just be guided here by the chair, Dr. Advani and others. So thank you, and I'm happy to give a quick case if you want, or as you like, I can stop.
Thank you so much, sir. I now request Dr. Deepak Shukla. Sir has a question for Dr. Mark. Deepak, sir, yeah.
Yeah, so sir, I have a question. I have a patient who initially at the time of presentation, he was EGFR mutant positive stage 4 adenoCA lung. Initially started on gefitinib, pemetrexed, carboplatin, progressed in CNS. So in spite of not having T790M mutation, started on osimertinib. And after a year, he has progressed with small cell transformation. So his leptomeningeal mets are controlled. So should we continue osimertinib with carbo-eto, or what should be the go-ahead treatment?
I think if the CNS is controlled, the temptation would be to continue with the osimertinib because it's compatible with chemotherapy. So I don't think it's a toxic combination. I think it's very compatible with, and I've used it with chemotherapy. So I think that's, if the resources permit, I think it's very reasonable to continue with the osimertinib because you don't want to get leptomeningeal disease out of control. That will be very rapidly fatal and very, very difficult to treat in any other way. So I would continue with the osimertinib. Obviously this patient has a bit of a guarded outcome, but you might get an extra couple of months of good quality life, perhaps.
Okay, thank you, sir.
So if any of our audience members, if they have any questions, they can just raise their hand and we'll unmute you. Till that time, Dr. Pradyuman, you were mentioning something.
Dr. Mark, can we have the case as well in the interest of time? If the participants have a question, and then we can go on.
Yeah, so would you like me to present a case?
Yes, that would be great, doctor. That's a real one.
Okay. So let me. Okay, so this is a 38-year-old female with no past medical history, never done anything bad in her life, lifelong non-smoker, teacher, physical education teacher, married, 2 small children, aged 1 and 3 years old, presented with headache and weakness in the left leg for a month. She had a scan, non-contrast CT scan in August 2015, showing bilateral abnormalities, frontal mass, temporal mass, and another one right at the top here, MRI, and chest x-ray just showed this lesion and some hilar adenopathy here on the right. This is the CT scan showing this lesion here, and the right to some adenopathy here, squeezing the right upper lobe bronchus, threatening to shut down that lung or lobe, and mediastinal adenopathy. This is back in September 15, a bone disease. You see this destructive bone disease in a vertebra here, with the spinal cord just over here, of course. And this is an MR of the face showing this mass in the antrum and a needle here with the local anesthetic, and the needle going right through into the maxillary antrum, obtaining the tissue, which was a poorly differentiated carcinoma favoring adenocarcinoma of lung origin, out negative, EGFR pending. We got a deletion 19. This is, back in 2015, so fairly primitive testing, but we did get it. The neurosurgery said she's too extensive. She was started on Keppra for seizures, partial seizures, whole brain treatment, left maxilla, 3000 centigrade in September, and then was told she was going to live for 6 months with 2 small children. She was referred to medical oncology. She started at that time in 2015 on a fatinib, 40 milligrams a day, and denosumab for the bones, and tapered the dexamethasone. And within a couple of months, the chest X-ray had improved markedly. She'd had no radiation here. This is purely due to the afatinib. We see the CT scan is improving. We see the adenopathy in the mediastinum is resolving nicely. We see the bones here. You see this big lytic area sclerosed up here very nicely. We see ongoing healing. This is a healing response, sclerosis in the bones. No radiation here. This is purely a systemic treatment. But this one has been radiated, but we see it's considerably improved. But there's always a but here with this drug. Grade 2 paronychia on the big toe, grade 2 facial RAS, 5 to 6 loose stools a day. We reduced to 30 milligrams a day, emphasizing loperamide. Started her on minocycline, addition of denosumab, as I've mentioned. And notice, by the way, that I like to measure CEA, CA125, CA99. These tumor markers had come down really quite nicely on this treatment, but she's now having problems with toxicity. Side effects are tolerable now at 30, but she's got paronychia, and that did not go away. In fact, it's getting worse. She has salts, Epsom salt soaks. It just doesn't get better. But she's controlled otherwise. And so she doesn't want to come off the drug despite having this big problem. But she's a physical education teacher. So every time she's jumping up and down with her feet, this is banging on the big toe. It's very painful. And so it's really difficult for her. But the chest X-ray remaining under control, March 2017, really continues to shrink. Bronchus remains open. Bones are healed. The CEA down for a long time. However, it's starting to tick up here a little bit in 2017. And she's still now having a lot of trouble with this paronychia. We did a T790 blood test, sent it down to the Massachusetts General Hospital, and she then registered because she had the T790 with the AstraZeneca Access program. But in the meantime, there was no clear evidence of disease progression. So we continued to try to manage these painful toes and the skin rash and so on. However, December 2017, PET scan positive for an antemediastinal node, and the CEA had ticked up a bit, and she received 30 gray and 10 fractions. And you can see basically the MRI. She had a new pituitary mass, by the way, but changed to osimertinib in March of 2018. And you can see very promptly the CEA. Don't worry about this. This is within the normal range. The CEA falls rapidly. CA125 falls rapidly. And very, very gratifyingly, the paronychia in the feet and the toes, which was very problematic, resolved rapidly and completely on the Tagrisso. And the CEA normalized and has stayed down more or less until quite late. So for months and months and months, she benefited on this. This is October 2019 now. We're now 4 years plus out from her diagnosis. She remained well. She's back teaching full-time, phys ed, active in school, denies headaches, no seizures, energy good. And basically she had very minimal skin rash here and was having really an excellent quality of life. And in November 2019, at that point, she was doing really well on the CT scans. At that point, she was now 51 months and she continued to work and look after her growing children. And that has actually been the case until very recently. So now we're October 2022. She'd been re-irradiated to mediastinum, and we were alerted by the rising CEA. She's still clinically well, completely asymptomatic and on the osimertinib, but the CEA now is starting to rise. We repeated a PET scan. PET scan shows very little, except perhaps a little bit of a node here in this area. And I will say that she'd had a COVID vaccine on that side. I don't know if that's related to the COVID vaccine or the disease. And we're now continuing to watch, continuing on the osimertinib, but the CEA is rising slowly. And we're hoping that this is going to declare itself in some localized way that we can re-irradiate or irradiate, and fingers crossed. But I just want to make the point here 7 years and 2 months after diagnosis and been told that she had a short time to live. And she's now 4 years and 7 months on second-line osimertinib. And this is a young adult in the prime of her life. And, 10, 20 years ago, she would have been cut down very quickly and died very rapidly. And she's had really a pretty good quality of life coming up now more than 7 years. And that is substantially due to osimertinib with the low toxicity, the CNS penetration, and the striking activity. So we'll see what happens, and fingers crossed. So that's a case, and appreciate that. I have other cases, but that's certainly, I think, an interesting case.
Deepak sir has raised his hand, so please go ahead.
So, sir, do you treat exon 19 EGFR differently from L858R?
No, we standardly we'd put them both on osimertinib up front and give them the same chemotherapy. And what to do after that, as I say, is a bit of an evolving situation. What I like to do, actually, if patients have got access and resources, I like to keep them both on osimertinib and add the chemotherapy rather than stop it. If the CNS is still good, under good control, I like to retain the osimertinib to continue to control the CNS, even if I add chemotherapy or even if I add bevacizumab, which I have occasionally done. But I don't treat them any differently at the moment. We have a very active and aggressive radiotherapy department here who likes to do SBRT. So, either case, if they have a persistent focus of disease activity that's symptomatic or not that well controlled, we will liberally use SBRT with either of these patients. So right now, we don't treat them any differently.
Okay. And any importance do you give to co-mutations in addition to the classic EGFR mutations if they are there?
So we certainly get this printout now because we have an NGS panel. So of course we're getting this information. So whenever I see P53, my heart sinks a little bit. And I kind of think in the future that those are the people who we might need to add chemotherapy on. So I think FLAURA2 is probably going to be a positive study for PFS. But the question is, does everybody need the chemo? And my prediction is that what it'll be is something like the P53 patients will need the chemo with the osimertinib. The P53 wild type patients may just get the osimertinib. I think it's going to be something like that.
Okay. Thank you, sir.
I mean, the other co-mutation, by the way, is that you will sometimes get an atypical EGFR with a typical EGFR. And our experience with that is that those patients respond very well, and we just treat them the same as the typical EGFR. And so even if they have an atypical EGFR on top of that, something like G719 or something, that seems to respond very well as well. So we don't treat those people any different either.
Thank you, sir. Thank you.
Thank you so much, sir. We'll now move on to the panel discussion. It gives me great pleasure to introduce our moderator, Dr. Amit Rauthan, Senior Medical Oncologist from Bangalore. His panelists are Dr. Mark Vincent, Dr. Shaunak Walme, Dr. Kaushal Patel, Dr. Nova Gupta, Dr. Ankit Batra, Dr. Bhuvan Chugh, Dr. Aparna Srivats, Dr. Deepak Shukla, and Dr. Krishnamani. So I'll now hand over it to our moderator, Dr. Amit Rauthan.
Thank you very much. Good evening, everyone. And good morning to you, Dr. Mark. So that was an excellent talk. You took us through the whole EGFR journey. And I think I love that the newer approach slide which you showed us. And that's amazing to see what the different lines of therapy, the way it will change in future. And it's really amazing to see. And I wish we'll get access to those group of drugs soon, because that will make a great change in the future of EGFR mutant positive lung cancer patients. Let me start off quickly with, I think let's do the early stage first as a quick discussion, and then we can just do the late stage. So welcome all the panelists. So we'll quickly take a few points off and just take a quick case to start off the discussion. This is a 67-year-old gentleman, non-smoker, presents with cough, and there's a lesion there in the left upper lobe. So this is the PET scan. Okay, I'll take it that way, that he had a lung mass and he had some nodes, and it is operable and he gets operated. And this is the histopathology report after the surgery. He has moderately differentiated adenocarcinoma, and it's PT2N1 M0 disease. So this is how this has come to us. So let's start off. Let me start with Dr. Kushal. How do you take this further in terms of testing this group of patients, single gene, multi-gene? What do you do for this early stage patients nowadays?
Yeah, good evening to all of you. It's a post-operative T2N1, I think, right?
Yes.
Yeah, so I definitely send the sample for the NGS in this, even in this early stage tumor. And would like to send the patient for the radiation oncologist to evaluate the patient for the any adjuvant radiation therapy because of nodal positive status. And further plan of the management according to the NGS report, whatever it is.
Okay. Very interesting. You spoke about radiation adjuvant because of nodal positivity. So that's something that we have sort of now moving away from much more than earlier. So that's very interesting. But NGS testing is what you're talking of, right? Dr. Novak, do you do single gene testing or NGS testing early stage nowadays?
So I for my early lung cancers, somehow I'll say unfortunately we do not get to see a lot of early lung cancers. But it is mostly the advanced diseases which do land up to us. That's one thing. The second thing is we are not doing NGS early stages. We are only trying to get the EGFR and the PD-L1 testing for the early stages as of now.
Right. Yeah, no, I think both points well taken. The numbers are really low. All of us are seeing so small numbers of early stage. And there's always this question, you do EGFR, we know we can do something. What do we do if we get something else? So a lot of people say, why test for everything together? So it's a changing space and it's a changing landscape. Professor Mark, what do you do? Do you test for multi-gene or single gene in early stage?
Yeah, we have reflex NGS testing now on anybody at any stage right now. We just think it's more efficient to do it. But I agree, we don't see that many people with early stage disease in this part of the world. But we will do reflex testing.
Right. So it is NGS is the way forward for everyone. Right. Okay. Dr. Ankit, to you, when you see this group of patients and you do testing and you end up with getting an EGFR mutation, T2N1, how would you want to proceed with further treatment? Dr. Ankit? Okay, I think I don't have Dr. Ankit there. Dr. Aparna, your thoughts on this group of patients?
Sir, I agree that the numbers are very less, but in Kidwai, we had a patient who was early stage just like this, and we gave chemotherapy, pemetrexed and carboplatin, and when EGFR hotspot mutation was tested, he was EGFR positive. So we actually gave Geftinib like a maintenance after 6 cycles of pemetrexed carboplatin. We gave Geftinib for 1 year. So that was how we managed that patient.
Right. So that was something which earlier used to be as a concept because we had seen the earlier DFS data from the older trials. And there was always that thing that there is at least a DFS benefit. The thought used to be there. I agree with you. That was earlier there. But then eventually the trials became negative. There was no OS benefit. So again, the whole thought comes really, is it really worth giving that Geftinib for 1 year? I clearly understand the way we would do it.
Hi, Dr. Amit. This is Dr. Bhuvan. Can I come in here?
Yes, Dr. Bhuvan. Yes.
So we have a fair bit of experience with early lung disease. We are a slightly high volume thoracic center. So I'm a little. In India, I don't think we are there as yet in reflex NGS. I probably as our in-house NGS labs get developed, probably it may just become a reflex for us also. It's just that. For somebody who's early disease, it's generally taken up by the surgeons. And I think the reflex probably would have to be initiated by the surgeons more than the medical oncologist there. And I think the other small, obviously every case ends up in a tumor board. But then what the first speaker said, radiation, I do agree with you. I think we have moved away from radiation when it comes to the, curative setting in a N1 positive disease, unless you're looking at a margin positive or a microscopic margin positive disease. And just to the last, Dr. Aparna, probably, I know, do you still do 6 cycles or you do 4 cycles with cisplatin base? So I just wanted to know I think we have moved to 4 cycles platinum cisplatin base. Is that what we're doing generally? Is it, or
Yeah.
do you disagree with that?
Yes, I think 4 cycles is enough. If a patient is able to tolerate cisplatin, we give cisplatin. Otherwise, we give carboplatin also.
What is
Right.
your experience, Dr. Amit?
Yeah,
Cisplatin.
so I agree with Dr. Aparna. We do 4 cycles, and though we do always say cisplatin is better than lung, but we still use carbopemetrexate in many of our patients, and I'm kind of comfortable with that. I don't think we're doing really anything too bad when we do carbopemetrexate. It's much more well tolerated, but 4 is good enough in terms of adjuvant therapy. I would only I agree with what you said, Bhuvan, but my only thought is, you will start getting the whole thought comes, you are not going to do NGS because you're not going to get the idea of what to do next if you have other mutations. But it's worth getting the information in lung, and eventually these patients are going to be referred to you as medical oncologists. So
No,
so
I
why not?
totally get the
You
point.
could
So,
take the testing.
as a Max Healthcare, we are developing an in-house center, and possibly, just at the data point of it, leave it whether we want to do something or not. Just at the data point of it, it'll be so fascinating to have early lung. What is the, I'm sure
Absolutely.
the evidence will, so as the more NGS we do, the more evidence we will build. Possibly, that's what I'm looking at.
Absolutely. I fully agree with you there. Right. So this patient turns out TGFR, it's exon 21. I'll put this to Dr. Deepak. How would you manage this patient now?
So, sir, we have data for adjuvant chemotherapy. So adjuvant chemotherapy possibly add to 5% overall survival benefit. So I'll give adjuvant chemotherapy, but with the data of osimertinib, I'll be tempted to give the patient adjuvant osimertinib for 3 years as in the trial.
Right. Any patient you don't give adjuvant chemo in your setting?
Sir, early stage possibly less than 1 centimeter, T1 lesions less than less than 1 centimeter.
4
But
centimeters.
again, as discussed, these patients are rare. Majority of these patients, what we see, tend to be in either stage 2 or 3.
Right. Okay. So the early stage. Dr. Vincent, would you leave the 1Bs, or do you offer the 1Bs all of them chemo, or are you a little bit on 1B this way or that way?
So it depends if it's less than or bigger than 4 centimeter. So if it's less than 4 centimeter, there is some evidence that it might actually be harmful, as opposed to just futile, but it might actually be harmful. But above 4 centimeters, we certainly discuss it with the patients. I looked recently at the American ASCO NCCN guidelines. They're sort of on the fence about it a little bit. They say with bigger tumors, you can discuss. Many people use the 4 centimeter cutoff. I don't know what's magic about 4 centimeters, but in our big Canadian study, we did find a 4 centimeter was a cutoff. So I don't know what the reason for that is, and I don't think anybody does, but it was also came up in the CLGB study a long time ago with carbotaxol at the 4 centimeter cut point with 1B. So we do if they're bigger tumors.
Right. And that whole concept of being harmful is so difficult to believe in the present era. Could it be because it was the old trials? Why would 4 cycles of pemetrexate carbo, even given to a 1A, would be harmful? I don't know. It could have been the older trial designs, older trial managements of patients.
Well, I think we didn't have pemetrexate back then. So these were, cisplatin vinorelbine or carboplatin paclitaxel. But there was evidence that in less than 4 centimeter smaller tumors that it may actually be harmful, and that evidence is quite solid there. It wasn't just a trivial effect. I don't know whether you're interfering with the immune system. That there's a yin and a yang and a balance, and that above 4 centimeters, the good outweighs the bad, but below 4 centimeters, maybe the bad outweighs the good. I think there's more going on here than meets the eye.
Right. Definitely. There's quite a lot we don't understand in these kind of diseases. Yeah. Right. Dr. Shonak, you would straightforward go for chemo followed by 3 years of osimertinib. Are you doing that now for your patients in early stage?
Yes, but if we speak about this case, technically speaking, his T size was 2.9. It's less than 4 centimeters. he's stage 2 for the fact because he has a parietal pleural invasion. That's why he's stage 2.
No, but
This
he has
patient in
N1
our
disease.
case.
Disease, right?
Yeah, he has
disease.
N1. Yeah, he has N1. So yeah, I would go for chemo and then osimertinib.
And if I put a 1B to you, would you be comfortable giving osimertinib for 3 years after the chemo, or would you not?
No, not very keen because I mean the data does support it, but the financial toxicity would be pretty evident in a setting like ours, and so I mean if there are no financial limitations, I think I'd go ahead with it.
Right.
Or, you know, and maybe 1B is an area where we can try for a shortened interval of osimertinib rather than 3 years. Maybe that's worth trying.
Okay, interesting thought. Bhuvan, 1B osimertinib, yes, no?
Yes, but then it's the toxicity profile of it. There are some patients who, there are majority of patients who tolerate osimertinib very well. There's this small subgroup who end up having a drop in platelet counts. There is decrease in appetite. So I'll probably not push through in them. Is that what I'm saying? Is possibly the toxic profile, which possibly may just put me off for that one small bit of a patient. Otherwise, I'll go ahead.
Right. Okay. So I'll just take the last word from Dr. Mark. 1Bs, are you convinced, and are you saying the benefit is good enough, or is that a group where you're not very pushy? For osimertinib, actually.
I think as I recall the data, the worse the stage, the bigger the benefit. So I think all of these things come to a very sort of discussion with the patients. I think there's still a benefit. If this was breast cancer, they'd be pushing it very strongly, right? Even small benefits in breast cancer, you've got to do. So I think you've got to discuss it with patients very carefully about what they can afford, because there is an access issue. It's very easy for us to say, just do it, but it's a big impact on some families. So you've got to discuss it very carefully, but I do think you are obliged to inform people about the data, rather than hide the data. That's an interesting question as to how much you have to tell people. Depends on their level of education and so on and so forth. But in general, you should default to giving them more information rather than less, and then letting them make up their minds.
Right. And I think we are in that era where we need to keep telling them everything which is there as the information. Dr. Nowak, what thoughts on you do you think this DFS is just good enough for every decision making, or do you think after stopping in 3 years, the curves are going to fall back just like the previous trials? OS is going to be significant. What are your thoughts on this?
I think, Dr. Amit, this is what maybe those I would want to see the OS, especially for those 1Bs, maybe. But till that time, I'm quite convinced with the DFS data. And for stage 2, stage 3, I would be absolutely inclined for the adjuvant osimertinib. For the 1Bs, it's a if and but, and maybe if I get to see the OS data, and then maybe I would be more.
Right. So I think all of us are very convinced. It is big DFS benefit. I don't think we've seen these hazards anywhere else. So we're all very convinced about it. Though we do believe some amount of the curves will fall down, but probably because of the CNS penetration, they should remain. The OS should be there. I kind of think the OS should be there. Dr. Kushal, your thoughts in early stage with neoadjuvant? If you have
in sense of TKI or chemotherapy or immune therapy.
So my thoughts is, what are your thoughts on maybe could it be osimertinib neoadjuvant for an EGFR, or could it be the new chemo IO approach?
Yeah, actually, till now we do not have any data of the neoadjuvant osimertinib or any TKI in non-small cell lung malignancy. So I reserve only chemotherapy in this particular subset.
Right. Okay.
So I'll just like to come in here. Have you had a discussion with one of my tumor boards? I think there was a lot of pushback from the surgeons in terms of chemo IO and neoadjuvant setting. So there was this entire discussion about chemo IO in terms of achieving a better PCR. But then there is a lot of apprehension, and there was this article by the surgeon I think in one of the conferences about neoadjuvant chemo IO. What is your take on it? Have you imbibed it in your clinical practices yet?
So we we have started giving the neoadjuvant data. Actually, when the NADIM study came out, we did use Nivo with chemo and neoadjuvant. And actually, we've had a patient who had PCR, and it is an amazing data set. And I think after 816, we are pretty impressed because there are this group of patients who you don't want to operate first, and we believe in it. But again, I agree with you. The thought will always come neoadjuvant versus adjuvant once the data starts coming out, and these are very, very interesting questions. But I am personally very impressed with the neoadjuvant data sets, and you could get away with just few cycles, and that's amazing. But this is all the non-EGFR space. Clearly, we are just talking of the non. In the EGFR space, I'm sure there's really not much role of IO, and I'm not a firm believer of IO at all in the EGFR space. Oh, I had a question for what are your thoughts on neoadjuvant osimertinib, Professor Vincent? Would you do it, or have you done it for some patients?
I've done, we actually published a couple of years ago neoadjuvant erlotinib in a patient who was actually initially unresectable. So we didn't realize it was neoadjuvant at the time, but it was a single huge football-like lesion in the chest in an elderly woman. And we gave erlotinib and it did shrink to the point that the surgeon said, you know what, I can now take this out. The surgeon did then take it out, and at that point we didn't know what to do. Do we continue on the erlotinib? Do we just stop? We continued on, rightly or wrongly, and then she relapsed after about a year and died. But it certainly converted this one patient from being inoperable to being operable. So I think in these borderline resectable or inoperable people, initially inoperable people, then I think you want to make them operable. I think that's where you can value a very high tumor shrinkage approach. And I think that the TKIs, either with or without chemo, are, I think, a consideration in borderline resectable people.
Professor Vincent, just as you bring it up, sorry, Dr. Amit, just small point. There's this, recurrent clinical problem we end up having, the oligometastatic EGFR NSCLCs. So now the point is, somebody who's oligometastatic, let's say, has 2 bone lesions. Do you keep your intent as neoadjuvant osimertinib and then CTRT to the metastatic sites, or is it just a purely palliative setting?
So, we're prepared to treat these people quite aggressively. So, for example, if you've got a single brain met, we can, our neurosurgeons take that out, and then we treat them, like a stage 3 or whatever. Or if they've got just a few metastases, we will treat them aggressively with SBRT to all sites of known disease, and but put them on the systemic treatment at the same time, of course, because they're at a huge risk of systemic failure. So, yeah, if they've got a few metastases that are accessible to local control, we will aggressively tackle those with SBRT or sometimes even surgery.
So let's say you do SBRT to the brain lesion and then you do chemo-RT to the lung lesion?
Yeah, like treat them as if they were stage 3, yeah.
And
do you put them on a year of durvalumab afterwards?
Yeah. That's my follow-up
that's another issue, right? And that's a funding issue. We wouldn't be funded for that.
Otherwise, had the finances not been a problem, you probably would have pushed for Pacific.
Well, certainly put them on an IO drug. Yeah, put them on an IO with the chemo. So they're, technically stage 4, so they would qualify for a stage 4 funding paradigm. But we would also, if it's just limited brain tumor out, stage 3, we'd irradiate that radically. And then, maybe add a Pembro or something and cross our fingers.
So I was just thinking, so instead of Durva, would a Pembro be a better choice in such a case?
Yeah, I think we would, we would be funded for Pembro, but not for Durva. We funded for Durva in the, in the PUCA stage 3, we funded for Durva. But if they were really a stage 4 resected, our funding system would tilt us towards Pembro or Ipi-Nivo.
Thank you.
I didn't get that thought. Bhuvan, you're talking of stage 3 EGFR positive. Would you give the IO Pacific Dike?
That's what the discussion was. So if you have somebody has
that's another thought we have moved away from in the EGFR positive space. In stage 3, we're not very convinced we are going to give the Pacific 1 year Durva.
Yeah, no, I didn't mean in the EGFR state. I just meant in general.
No. So I'm asking about somebody who's let's say oligometastatic stage 4, and let's say I do SBRT to the brain lesion, and then I'm treating the lung lesion as a CTRT, the standard stage 3 way. So are we doing IO for a year or not is the question, Dr. Amit.
So again, I missed that. You're in the EGFR space?
EGFR space, somebody has a
Okay,
somebody
no,
has
so that's where we are not convinced about the IO at all, you know. So the Pacific data had so small numbers for the EGFR positive, and now when we have the TKI data, actually we have moved away from the Pacific data sets for the EGFR positives. We are not offering 1 year of Durva for our stage 3s now after CTRT also. So it's a different space, I'm sure. I didn't put that question. So my question was there in 3Cs, 3Bs, what do you do after CTRT? So you still give them 1 year Durva?
Professor Vincent, I think so. I'll take it after you take it. So in a EGFR positive stage 3 after CTRT, do you do the Pacific way or do you go the TKI way?
Well, until recently, we did Pacific because that's what we were funded for. And in the stage 3, we're not funded for osimertinib or TKI. We're just not funded for it. My preference, actually, if money is not a problem, would be to go with the TKI.
Okay, so
rather
possibly
than
till today I go for a IO way, but then now listening to you guys, I probably will end up doing NGS for everybody and go for a TKI. But then, as per the guidelines, it is still the TKI. It's still the IO,
yeah. No, I agree. The guideline was still because of the way the data.
I understand. But then
I would say in the last. So my belief is this way. You say from 1B to 3A, you believe IO doesn't work, and from 4, IO doesn't work for an EGFR positive. Why do you want to make 3B a difference and say IO will work there? So IOs don't work. IOs don't work in EGFR space. But that remote possibility is there. That's fine. But as a whole, I think I would go the osimertinib route.
No, so I don't think it's just about the. I think any driver, be it breast cancer also. If you have a driver mutation, possibly IO doesn't work. And I do understand that. And I think it's just been there.
It's there in the guideline. It's clearly there in the guideline, as you say.
We do not have any hard data post CTRT for osimertinib, is it?
Absolutely no. For 3, the trial stopped at 3A, so we don't have that data for 3B and 3C. So that's a problem. But it's an extrapolation all of us have started doing, and I know we don't have data sets for that. But you keep thinking, that's if it's going to work from 1B to 3A, it's going to work for 3B also. So these are extrapolations we do in practice, but the decision making of IO versus TKI in this setting post CTRT, we as a center consciously moved away from Pacific for this reason, for at least for the last year or so. So anyway, let's move forward. Now we're talking of metastatic EGFR. Quickly, I don't know how much time we have left. Let's quickly go through it. One last question, okay, for the operated setting, Aparna, to you. I recently, just some time back, had a patient operated, and we did an NGS. It turned out she has ROS1 positive. Now, let me tell you, T2N1 ROS1 positive. Would you offer adjuvant?
Adjuvant chemo followed by TKI, sir.
For a ROS1, would you give something? Or for an ALK1, would you give something? What is your temptation there?
Also, sir, I don't think there is data for adjuvant TKI for ALK positive or ROS1, but just extrapolating the data, usually this T2N1, they tend to relapse within a year or so. So there is, I would give chemotherapy followed by TKI, sir.
Yeah, you're absolutely, there's no data at all. It's only chemo. The trials are just going to get started. Dr. Vincent, if you had an ALK positive, would you be tempted by any chance, or if it was funded?
I'd be very tempted. It would really depend on the risk factors, looking carefully at the pathology. But if I thought this was a high risk for relapse, I'd be quite tempted to do it. You always think, what are you going to do if you were the patient yourself? If I was the patient, I'd get myself onto an ALK inhibitor. I certainly would.
I know.
It's not data driven. It's driven by extrapolation. I actually think data will never ever cover every situation. So I think you have to have a room for extrapolation and judgment, and try to do the best what you can for your patients in the individual setting. And I think data extrapolation is, by reasonably intelligent, experienced, and educated people, is a very reasonable approach.
Right. No, I think you're right in many ways in this statement. Okay, moving on to the metastatic EGFR space. Quickly, we'll just talk about a few situations. So you have a metastatic positive patient with EGFR with high PD-L1, 90% PD-L1. Dr. Kushal, how would you see this group, this patient?
Yeah, this is a tricky one, but I will still go with the TKI, preferably the osimertinib.
Okay, right.
Once
And
the disease progress, because I have one patient who is EGFR positive with PDL1 is approximately 60%. Initially, I started with the dacomartinib progression, then osimertinib, good response. Progression on osimertinib, then I started with the Keytruda, patient has complete response, then once again progression. So in this particular subset, both the drug will work. But as per guideline, I would like to go with the EGFR TKI, preferably the osimertinib.
right, so clearly avoiding IO and using the TKI is the way forward. Sometimes you have a very symptomatic patient and the PDL1 report comes in one day, you know, and then the next day you have the PDL1 report and the EGFR is not going to come for at least maybe 4 days, 5 days. Dr. Novak, in such patients, are you 90% PDL1? Does your temptation change? What do you do for such group of patients? You don't have the EGFR yet, 90% PDL1, symptomatic.
Yeah, so seeing this is you would be kind of inclined. The patient is symptomatic and very high PDL1 positivity. Maybe you would have I would have offered a PDL1 along with the chemo for this patient, but then again, first cycle would be just you feel it's a young female non-smokers. Maybe those settings you try to hold the IO and just give the chemotherapy first cycle and then wait for the EGFR report.
Right. So definitely we could give just chemo as the first cycle, waiting for the molecular reports before we do that. Definitely. Dr. Shonak, Novak said that female, he would have done it. Now I put a smoker symptomatic PDL1 90% EGFR report not yet there. Are you changing your thoughts? Like, are you going to give first cycle chemo or chemo IO?
No, I'd still stick with chemo for the fact that again, the financial burden for immunotherapy is still high. By the second cycle, you'd be getting your EGFR and molecular panel reports. And plus one cycle of immunotherapy is in the metastatic setting. I'm not sure it's going to relieve his burden so soon.
Right.
So I'd stick with chemo and then wait for the report.
I think that's the best thing to do. All of us sometimes get tempted to add the PDL1, the PD-1 inhibitor directly, and I think that's something we should avoid. It's best to do the chemo itself. And even though symptomatic chemo works well for these patients, it's not that it doesn't work well. And we could always have the report and we can make changes as we go ahead. So I think that's one thing all of us have learned. Don't do the IO, and especially when we talk of the toxicities which happen with IOs, and if you have given the IO already and then give PDL1, the TKI after that. So anyway, the data is clearly there about this, and we have seen all the data sets saying no benefit, not in using IOs in this group of patients. Now, oligoprogression, Bhuvan already touched on this. I would put this to you, Bhuvan. What do you do for oligoprogression? Do you just radiate and continue osimertinib? So put 2 points there. If you had oligoprogression and if you had progression, what do you do?
So oligoprogression, clearly treat the oligoprogression and move forward, as in move with the same drug. Or let's say the person is osimertinib, you still have a durable response left after osimertinib. With osimertinib, not after osimertinib, sorry. With oligoprogression, treat. So just to summarize it, oligoprogression, treat oligoprogression and continue osimertinib.
Okay.
Somebody who's had a progression, I again look at it. So I think when you come to the systemic therapy, what I have possibly learned out of my experiences, that when you switch off the systemic therapy which is going on, thinking that it is not working, it is super detrimental. So you just think that the patient has had 2 or 3 progressions. Even at that also, I probably may just continue. Somebody who has had a symptomatic progression, I obviously would be, very, very keen to change the drug. That is the time, that's possibly the time I tend to change the drug. And that also I tend to do a NGS. I have had patient in which one driver has led to another driver. So I had one osimertinib who progressed, had RET and BRAF, and post that had ALK, and post that had another ALK. So what I'm saying is you do not know what is driving your tumor forward once you have had a progression to osimertinib. My rule is to do NGS. While waiting for the NGS, I end up starting a weekly Pacli carb or something, so that I know that by the time the NGS comes, what I'm going to dealing with.
So I go with that's exactly what we would all do. Send an NGS, see what comes out. Now my thought is, if you don't get anything in the NGS and you're going to give chemo, even in progression, if the brain is okay, experts again say no, we want to protect the brain and continue osimertinib. But that way you will be on osimertinib forever. What do you think of that?
So unless there is I have done that. I've done chemo plus osimertinib also, because I certainly believe that there is a huge deal of systemic control which is being given by osimertinib. I know it's more of a data-free zone, but then switching of osimertinib can lead to I'll not like to use the word hyperprogression, but then it may just be detrimental, is what I feel.
Right.
If
so you're right. I fully agree. You're right. But Dr. Vincent, then no one will stop osimertinib. What do you think?
Well, it depends who's paying, right? So if the government will be government's very quick to stop these things if it's outside the data. If the patient's got, financial resources, I would continue it actually, as long as I believe that it was contributing to especially CNS control.
Right.
But you can add, the thing about osimertinib is relatively non-toxic drug. You can add other treatments to it. You can add chemo, you can add bevacizumab, you can splice in radiation, you can add a MET inhibitor. So this is a big decision, what you have to do here. We're making decisions under uncertainty.
Right.
So you have to, the patient is your partner here. You have to make this joint decision about what access, what resources can contribute.
Yeah, I kind of have that difficulty, because if the brain progresses, then it's easy. Then you say the brain progress and osimertinib can be stopped because you're not really protecting the brain. But when you don't progress in the brain and you progress elsewhere, you get into this trouble of protecting the brain. And I'm sure these are discussions which get more and more complicated, especially in the ACT space, when we start moving into all those brain protecting agents, because they will go on forever. They will never stop that way as you keep protecting the brain. Deepak, so you have a progression, you did NGS, you did not have any drivers. What are your thoughts? What do you do in that group of patients? Especially put your thoughts on IOs at progression, IMPOWER 150 like regimes. Do you use it, and what are your thoughts on that?
So, sir, you are talking regarding means clear-cut progression, no oligo.
Clear-cut progression.
So now at that point of time, we have data from IMPOWER 150. So if patient is affording and patient was on osimertinib and then progress, then this is one of the regimes which can be considered. But anyhow, pemetrexate platinum-based chemotherapy with bevacizumab, with or without IO, should be an option. If no targeted NGS means targeted approach is possible following progression on osimertinib.
And do you do it? Do you use the IMPOWER 150 regime in practice?
Yes,
have you done it?
Yes, sir. I have used it only once actually. So I think disease control was there for almost 6 months, but not very commonly.
Okay, Kaushal, your thoughts? Do you at progression, no drivers? Do you use IO in like that combination?
Yeah. I will try definitely, because there is no other option available with us at that moment. So one option would be that we can continue with the IO and adding some another chemotherapeutic drugs also.
Okay. Dr. Mark, what are
Dr.
your
Amit,
thoughts about
just
this?
a small question.
Yes.
Do you let anybody from lung cancer die without IO?
So this EGFR space is very tricky, So I was coming to that question, Dr. Mark. Do you believe that IMPOWER 150 data post progression really is a good data set? Do you really want to use that IO in that progression setting?
I'm not that enthusiastic about it because it's a small number of patients. So it could just be statistical noise. And most of the world believes that they should get more data before they believe it. But it was a signal. It was definitely a signal. And if your back is to the wall, I think it's an option to be considered. But do I believe it? I don't disbelieve it. I neither believe it nor disbelieve it.
Right. Okay.
I'm firmly on the fence.
Right. I think that the Pembro trial will answer this in that question of using only the EGFRs and then doing it. It's a very tricky question. So what at least with the patients which we have done it, I've really not seen that long-lasting response which you normally would have with that IO combinations which you see in other patients. But again, our numbers are small. But as you said, Bhuvan, it sometimes becomes difficult not offering an IO to your patients, and that's something that you keep hoping for. You'll get that long-lasting response, but it's really not there. I think we are running short of time, and I think we've covered everything. And it's a very very interesting discussion. But anyway, I think we'll stop here. We've covered almost all the topics. That was great. Okay, thank you very much, everyone. Thank you for that excellent discussion. And I thank the organizers for giving me this opportunity. And it was lovely listening to you, Dr. Mark Vincent.
Well, thank you for the opportunity, and wish you all the best, and hope the COVID situation is coming under control in India as well. So.
Right. Okay. Thank you very much. Over to you, Kashish. Okay. I think we can conclude, and we've learned a lot in the CGFR space, and I think good night and.
Thank you, Dr. Amit, sir, and thank you, Dr. Mark, sir, for joining from Canada, and thanks all the panelists. Wish you all a great evening ahead, and good day to Dr. Mark Vincent as well. Thank you
very much.
Thank you.
Thank you.
Thank you to all our participants as well, and we hope to see you again. Thank you, everyone.
Thank you.
Thank you.